Welcoming Wellness is a mental health initiative of White Plains United Methodist Church. You know, mental health is a sensitive subject. It's sensitive to talk about, it's sensitive to hear about, it's sensitive to experience. So if you get overwhelmed or you feel the need to get up and move around, please do that. We're very pleased to have Dr. Micah Krempasky here. She's a psychiatrist and she holds the title of Chief Medical Officer for Mental Health and Wellbeing at WakeMed and hospitals. And she's going to discuss the role of medication and the role of a psychiatrist in going from mental illness to mental wellness. Dr. Krempasky.
Hi, everyone. Thank you for joining me this afternoon. You need to be empowered with knowledge, and you need to understand psychiatric illnesses, mental health issues, to be as empowered as you can be for your own health and for the health of your loved ones and for the health of our community. Again, I am a psychiatrist. What does that mean? I think there's a lot of confusion about what the role of mental health providers are. Do I see a psychiatrist, a psychologist, a therapist? It's very, very confusing. So what I will tell you is that a psychiatrist undergoes all the training of any other medical doctor as the baseline foundation. So when I finished college, I took all my pre-med requirements, I took all the same tests, and I went to medical school like all other physicians. And so I spent 4 years, in the operating room, in the emergency room, learning about internal medicine, pediatrics, all of medicine. And then at the end of that, I decided that I wanted to focus on psychiatry. And then I did 4 additional years of very specific training. And so the psychiatrist's role in the medical team today is that we are the professionals that are charged with understanding every piece of mental illness and putting it together. So looking at how physical health impacts, so we understand all, not at the deepest level that like an internal medicine doctor would, but we understand the basic concepts of physical health, of mental health, of therapy, of medications, and we put all of that together. So then there are other health professionals that are part of the teams as well. So like psychologists may have their doctorate, have PhD, they do a lot of research, testing, they're great at therapy. We have therapists who can be master's level clinicians who help do the therapy. My therapist is a master's level clinician because psychiatrists are not particularly well trained with therapy anymore. We get some of it, but we get a much broader overview of all the things that we talked about, where a therapist really focuses in on therapy. So I love that my therapist is a master's prepared clinician, and I feel like she has the expertise that I really needed to help me work through my own coping skills and get the support that I need. So that's kind of the basis of who I am and what the role of a psychiatrist is. Let's go to the next slide. So let's also get a framework for what we're talking about. To understand mental health and mental illness, we need to define what it is and be aligned on a definition of what mental illness is. So I get this question all the time about, well, is that a mental illness? I don't understand. So here you see the definitions from NAMI and from the American Psychiatric Association. That's my professional organization as a psychiatrist. So NAMI defines a mental illness as a condition that affects thinking, feeling, and mood. And it may affect someone's ability to relate to others and to function. That's a really important part. It impairs the ability to function. And each person will have different experiences, even when someone has the same diagnosis. So we see it's going to look different, but it has to impair function. Just because you have symptoms of something and it doesn't impair your functioning, then that may just be part of who you are. It may not actually be mental illness. The American Psychiatric Association defines mental illness as a health condition. Again, defining this is not a choice. This is not a judgment. This is not a moral failing. It's a health condition which involves changes in thinking, emotion, or behavior, or a combination, and they're associated with distress. So now we've got that functioning, and you're experiencing distress. And then again, it says functioning in social work or family activities. Next slide. So what about the prevalence? The American Psychiatric Association says nearly 1 in 5 people experience some form of mental illness. 1 in 24, about 4% of the population, has a serious mental illness, and 1 in 12 has a substance use disorder. those statistics change and they look a little bit different based on what source that you look. In fact, on a slide later, I have a different one quoted, but somewhere between 1 in 4 and 1 in 5 people experience a mental health disorder every year. So, psychiatric diagnosis. What happens when you come to my office and you're seeing a psychiatrist? What happens when you come in? What am I thinking? So when you come into my office, I'm going to talk to you a lot. I'm going to interact with you, and I'm going to ask you a lot of questions. Unfortunately, mental health, the field of mental health, is not to the place where we can scan someone's brain and know exactly what's going on like we can with other medical disciplines. And I also can't draw your blood and be like, yep, you have depression. Those are pieces that I need to know. I need to know if there's a medical reason for your symptoms. I might want to know what's going on with your brain if you're experiencing psychosis or something like that. But mostly, I'm going to get the information I need from conversation with you and from interacting and watching behavior. So psychiatry is about taking a pattern of behaviors, thoughts, and feelings and help putting them into a category. And the book, the overarching way that we diagnose, is based on the DSM, the Diagnostic and Statistical, hard for me to say, Manual of Mental Disorders. And that's published by the American Psychiatric Association. So this is a book that has all of the diagnoses, all the categories that help us physicians think through what diagnosis or what pattern of disorder or pattern of behaviors that someone might have. Have you guys heard of the DSM before? So I remember in residency, them saying, you need to read this book. And I was like, are you kidding me? That's a really thick book of really dense reading. But I think I've made my way through most of it through my career, but it is not used to lay on your bedside table and read at night, unless you just really want to go to sleep. But it is a great way. I pull it out all the time to just go back and refresh myself on, let's go back to what the description is. How do those symptoms fit together? And so today, I'm going to walk you through some categories of diagnosis per the DSM that help us understand groups of symptoms that go together. And I think it will help you have a framework for how the terms that we throw around, like depression and bipolar disorder and schizophrenia, how they fit into a framework that your physician is thinking about when they're sitting with you and trying to make a diagnosis if you were going to someone for treatment of mental illness. So here are the categories of diagnoses as they sit in my brain and as defined by the DSM. So we have mood disorders, thought disorders, anxiety disorders, trauma-related disorders, and personality disorders. So this is the most, probably the set of diagnoses that we talk about the most. So when we say that someone has a mood disorder, we're thinking along things that affect how we feel in general. And we often talk about that in terms of depressed. And we think about the poles being like, I feel happy or I feel sad, right? So when we think about mood disorders, they come on a spectrum. And this is where a lot of people don't know that the opposite end of the pole is you have depression on this end and bipolar disorder on this end. So depression is when your mood it's characterized by moods that are low, blue, blah, and down. So any human being has fluctuations in their mood. Sometimes I feel good, sometimes I feel bad. Sometimes I'm happy, sometimes I'm sad. That's normal life. We should all have some variation in our mood. But what happens when you're in depression is that your mood stays low and goes there for a while and doesn't come out. So for a significant period of time. And it's not just about feeling blue and blah, but there are other key characteristics that go with it. You will have low mood, decreased interest or pleasure. You just don't enjoy things the way that you used to. We can see weight changes. It can be both positive or negative. Some people gain weight associated with depression. Some people lose weight. You can see changes in sleep. Some people sleep more. Some people sleep less. People feel they can have some agitation, or they can also get where they really just don't move very much. So there can be a lot of differing pieces. That's why it gets complicated. But there's often a lot of guilt, worthlessness, inability to concentrate, and sometimes people can think about recurrent thoughts of death. So on the depression end, low, blue, blah, not sleeping well, loss of interest, loss of pleasure. On the opposite end of mood disorders is what we call mania. Mania is when you feel so good that you don't even know what to do with yourself. I like to call it the Energizer Bunny for no apparent reason. So much energy that like you don't need to sleep, you don't need to rest, you can just go, 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 go. Now, when I'm cleaning my house, I can get a little manic is what I say, and it lasts for about 10 minutes. And then I'm like, oh, that was enough. So mania is not that burst of energy that we all normally get when something is exciting, but it is a sustained period of not needing to sleep and having so much energy and having impulsive behaviors. So when I have someone and I'm trying to understand if they've ever had an episode of mania, I will say, what's the longest period of time you've gone without sleeping? And they'll tell me. And what I'm looking for is 2, 3, 4 days where you say, I just didn't need to sleep. I had so much energy. I was up doing things for 4 days straight. That's cueing me in to think about mania. So why is this important? Well, on the course of mood disorders, if you've ever had one instance of mania, that gives you a diagnosis of bipolar disorder. And that is incredibly important to me as a physician because it changes what medications I would give you. Because it turns out that medications to treat depression can actually throw someone into mania if they have bipolar disorder. So it's incredibly important to tease out, even if you stay in depression most of the time, and that is what's most characteristic of your mood disorder. If you've had any of those symptoms of mania, the very medications to treat the depression may make you worse. So these are the things I'm thinking about when you're sitting with me. This is why it's really important to understand the symptoms because, again, we're not drawing blood. And people will sometimes say, I'm manic depressive. Well, what does that mean? Or they tell me they have depression and bipolar disorder. Those are actually, again, on the same spectrum of disorders. Depression is you just stay on the low end, and bipolar means that you've had at least one episode of mania. Does that make sense? All right. Next, thought disorders. So these are disorders like schizophrenia and schizoaffective disorder are the two most common. So thought disorders are dysregulation of the dopamine system in your brain, and they literally impact your ability to think and how your thoughts go together. They're chronic illnesses. These are usually called our severe mental illnesses because they really do impact you over the course of your life. And once they develop, then you kind of never return to baseline. They're defined by both the positive and negative symptoms. So a lot of people define thought disorders like schizophrenia. We talk about people, we might see them that they talk to themselves, hear voices, see things that aren't there. And that generally gets associated with schizophrenia, but schizophrenia has so much more that goes with it because literally the thought pathways in the brain are disruptive. And in that situation, people who have these diseases tend to lose affect on the face. So the face kind of flattens. They don't show as much emotion in their face. Their thoughts tend to slow down and be less prevalent, and they tend to use less words and talk less. Those are the big words on the right that I actually had to look up the meaning of this morning because we try to make mental health unapproachable by using words like that. So when we read about it, there's all these terms, and you're like, how can I possibly understand it? I don't know why we talk in that lingo, because when I, the physician who sit and does this every day, has to look up the words, maybe they're not that effective in communicating. So again, thought disorders like schizophrenia and schizoaffective disorder are when the dopamine gets dysregulated and really a whole cluster of symptoms that impair the ability to think and include things like hallucinations, hearing voices or seeing things that are not there. Next, anxiety disorders. So the next class of disorders are the people that experience things that we know as anxiety or panic. So anxiety is your brain playing tricks on your fight or flight response. So we are all wired to survive. And if I'm in the jungle and there's a tiger coming at me, I need to be able to protect myself. So my body has an adaptive quality that I can turn on my fight or flight response. When I'm in danger and I need to get out of somewhere, my heart starts racing so that it can pump blood faster to help me run. My eyesight gets really keen so that I can see all the danger around me. My hearing gets really, really tuned in so I can hear the danger and to know how I need to respond. And that can let me turn on my flight and get the heck out of there and get myself to a safe spot. What anxiety and panic is your body hijacking that flight or fight response at a time when you're not in danger. So you can be sitting somewhere and your body perceives quickly that you're in danger and it turns that whole system on. And now you are in a state of anxiety. If you have that anxious feeling that comes and stays, we call that just kind of routine anxiety. And then people who have panic have the anxiety that comes that just has a death grip on you, like completely freezes you, feel like you're going to die, overwhelms you, but it peaks and then goes away in a couple of minutes. That is characteristic of panic disorder. So anxiety, where the one focused on mood, then we thought about the mental illnesses that focus on thoughts. Anxiety is that fight or flight response being hijacked, your very own body systems kind of turning against you. And this is really important because anxiety disorders are often treated using therapy. That's one of the gold standards of treating anxiety disorders because you have to train your brain to say, I'm not in danger. Look, I'm going to use my brain and recognize there's no tiger coming after me so that we don't go to those automatic thoughts of, oh, I heard a sound, I must be in danger, and your flight or fight response comes on. Okay. Trauma-related disorders. This is probably the biggest area of research and development happening in mental health right now. We do not have a full awareness of how much trauma impacts us and the lifelong impacts that it has. We've long known about PTSD, post-traumatic stress disorder, which is a cluster of symptoms that happens after someone experiences life-threatening trauma. But we're also recognizing that trauma now impacts our ability to cope. It impacts our lives in a variety of ways and may even impact how our genes are built and how they are expressed in our bodies. So trauma, when we think about a trauma-related disorder, historically, we have said it had to be a life-threatening trauma or something where you really were in severe danger. But we're also learning that just repeated trauma, emotional trauma, physical trauma, really impacts us, even if it wasn't life-threatening. Just repeated exposure to trauma can change the way our brains think and our ability to cope. The trauma-related disorders include PTSD, acute stress disorder, and adjustment disorder. And people can have re-experiencing dreams, nightmares, avoidance, where they start to not go places that they might be reminded of the event. And they can have increased arousal, always on guard, wondering when the next shoe is going to drop, when's the next thing going to happen. Can have some relationship to anxiety as well. Next. Personality disorders. So this has long been a set of disorders that called personality disorders, but it has nothing to do with your personality. Sometimes I just feel offended by this title. Like, what can you say about my personality? I thought it was quite charming. Rather, it's about a coping pattern. And these are disorders that develop when the person and their own needs are a mismatch for their environment. So they are an impact of the environment around you and how you experience it. They're broken down into three categories. Cluster A is when someone might be odd or eccentric, and that's the way that they cope and kind of show up in the world. Cluster B, people can be dramatic or emotional. That's what my family would characterize me as. And then cluster C, anxious and fearful. And the one that gets the most attention and the one that we see most often diagnosed is the next slide, is borderline personality disorder. So borderline personality disorder is a pervasive pattern of instability in interpersonal relationships, self-image, and self that comes, again, when the parent's ability to parent is mismatched with the child's needs, and it changes the way that they form attachment. And it ends up with a person experiencing an unstable sense of self, such that they're not able to regulate their own mood and really their definition of who they are. And so they have very tremendous mood swings over the course of the day. And this can often get confused with bipolar disorder. And we remember when we talked about the mood disorders and you had to have the mania or the depression that lasts for several days. Borderline personality disorder, it's a change in mood multiple times per day or just very frequently. It doesn't have that sustained change in mood. So again, this is all to illustrate that we have to get things into the right box or the right category, which is an inexact science, but it's really important to do that because the treatments change depending on what the cluster of symptoms are and how they fit together. And what might be right for one cluster of symptoms, for example, bipolar disorder, is a very different treatment than you might get for something like borderline personality disorder, which would be much more responsive to therapy. So, we had those classes in mental illness. Is addiction a mental illness? Or is it a choice? Is it a moral failing? There's a lot of debate around this, and people have really strong feelings about this. I would say the same was true of mental illness 20, 30, 40 years ago, 50 years ago. I think that we've had, as a society, very strong beliefs that mental illness, just pull it up by your bootstraps, like just get better. But I think we've moved in our understanding, and we have accepted that mental illness really has a lot of basis in our genes, in our brain chemistry. I think we've accepted that. But addiction still remains in question for a lot of people. Next slide. So we always like to define things. What do our experts say? So the National Institute on Drug Addiction says that, sorry for the eye chart here, addiction is defined as a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful consequences. So when kids, and they would try to do something dangerous, like they would touch the stove, we say, no, don't do that. But we also know if they touch the stove once, they're not going to do it again, right? Like we as human beings do not repeatedly do things that are bad for us. Our brains and our adaptive capabilities are much better than that. We do not repeatedly stick our hand on a hot stove and burn ourselves over and over again. Yet with addiction, people make choices that burn them, and yet they do it over and over and over again. I think that's a really important piece to understand because that goes against human behavior and kind of the natural way that we protect ourselves. It also says it's considered a brain disease because the drugs change the structure and function of the brain. And lastly, the brain changes can be long-lasting. So addiction changes how our brain works. It changes the structure of our brain and goes against it. Like anxiety, it hijacks our natural pathways. The DSM, remember our book of psychiatry, says that substance use disorders are a cluster of cognitive, behavioral, and psychological symptoms indicating that an individual continues using a substance despite significant substance-related problems, again, going against human nature, and involve an underlying change in brain circuits that may persist beyond detoxification. So it's not just while the drug is impacting your brain, but long after the changes to the brain continue. So to understand this a little bit more, we have to learn about dopamine. I heard that this was going to take us back to high school science classes, but dopamine is the neurochemical in our brain that goes with reward. When I eat chocolate cake, I love chocolate cake. My brain gives a big shot of dopamine and says, this is really good, and you should seek more chocolate cake. And I do. Right? So then when my kids decide that they're going to bake and I smell the chocolate cake, My brain gives off a little spark of dopamine and it says, I really like that. You really want some of that. And it gets me to go. And then I take a big bite of the chocolate cake and that spike of dopamine happens again. And it's like, you really, really like that, right? So this is how our brain, again, adapts to teach us to seek things that are good for us. That's debatable whether chocolate cake is good or not. Sugar can hijack it. And to stay away from things that are bad for us. I do not get a shot of dopamine when I touch a hot stove, all right? So addiction, we have to understand that reward pathway that happens in the brain to understand what's happening. So the drugs of abuse target the brain's pleasure center. So when I eat my chocolate cake and I get my burst of dopamine, I feel good. I am happy. And I take some cocaine, I get a huge release of dopamine, way more powerful than the chocolate cake ever would give me. And let me tell you, I think about this when I seek that chocolate cake and I smell it, that's powerful for me, pales in comparison to someone who's using drugs would experience. And so I just have to put that in perspective for myself. I'm like, that is really powerful. Here's an example of just how powerful it is. So when I eat food, something my body needs to nourish me, my dopamine levels go from 100% to 150%, so 150% of normal levels. Sex, our ability to procreate, to keep the planet going, 200%. Cocaine, 400% of normal dopamine levels. And methamphetamine, 1,100%. Cake is meaningless at this point.
Yeah.
Right? Can no longer feel or understand pleasure the same way you did because your brain has experienced it on a whole different level. And it doesn't necessarily know that methamphetamine is bad for you. It just says that was some good dopamine. Like, give me more of that because that's the way it signals itself. Now, what happens then is when you take the methamphetamine or the cocaine or the drug or the alcohol, whatever it is, and you get your huge rush of dopamine, the brain is really smart. And it says, that was good, but that volume was a little much. We need to turn that down. And so it down-regulates its receptors such that the next high is not quite as good. And then so that goes into a pattern of people continue to seek the high that they got the first time, which your brain has said you can't do because that was a little much. And then later on, after that huge release of dopamine, it has to make more and it goes into a deficit of dopamine. And so then the other thing we need dopamine for is thinking and motivation. There's a lot of things that it does. So then it gets totally depleted and you have no energy, no drive, no ability to think. So it becomes this up and down. And when we do image brains about the density of dopamine with methamphetamine use, the brain on the left is a normal brain, where red is the deepest concentration of dopamine, and then it goes lighter to green. To the middle one is someone who has been abstinent for 1 month. You see that they have a significant shortage of dopamine in their brain because all the chemicals got dysregulated. And then the good news is it takes about a year, but your dopamine will regulate itself after abstinence, but it takes a year. So these are long-lasting changes that impact the very basis of how our brain communicates and functions and take a very long time to get back to normal. But they do get back to normal. Next. So I'm here to tell you that substance use disorder is indeed a mental illness. And I put it as one of the categories when I'm thinking about which bucket I'm going to get symptoms into. Next. We also have to think about that substance use often goes hand in hand with other mental illnesses, and we call that co-occurring disorders. And we know that drugs of abuse can cause symptoms that are similar to other mental illnesses. So we have to tease out, is it the drug use that's causing that? Is that happening naturally? An example of that is bipolar disorder. When I say, what's the longest period of time that you went without sleep? 5 days. What were you doing during that 5-day period? If they tell me that they were high for that period of time or using drugs, then that may be related to their substance use disorder, versus if no substances were involved, that would be more typical of bipolar disorder. But many times it's really hard to tease that out. Drugs of abuse can be used to self-medicate. So when you're feeling really bad and you're feeling depressed, you can use drugs of abuse to increase how you're feeling, increase your mood. If someone is feeling really manic, like we talked about, they don't recognize that it's a symptom, they may use downers to bring their mood down and help calm them down. A lot of times people use alcohol to help them sleep, not recognizing that their sleep disturbance may be related to mental illness. And then the other part is similar factors can increase the risk of substance use disorders in the same way that it can other mental illnesses. So we really think about addiction and the other diseases that we talk about going together. So what's happening here? What's happening in our area in North Carolina, in Wake County? So these are some numbers that we use. This is a WakeMed slide. But we've done a lot of research around this lately to understand what's happening in our own community. And at WakeMed, we have seen a 15% increase in adults and children presenting to our emergency rooms. And when those people present to our emergency rooms and the psychiatrist sees them and says they need to go to inpatient care, their illness is so acute or so unstable right now that they require our highest level of care, which would be inpatient care. Only 50% of those patients ever get to an inpatient hospital. And when they do get to an inpatient hospital, it takes about 2.2 days on average for them to get there. That's because when we look at the number of inpatient psychiatric beds available in North Carolina, we have about 22.68 beds for 100,000 people of population. So when we look at national standards, a high-functioning, healthy community would have 22.68 mental health beds, hospital beds available for every 100,000 people that community has. But currently, what we should have is between 40 and 68, and what we do have is 22.68. We have half the number of beds that we would want for a healthy, high-functioning community. Which is why when people show up to our emergency rooms or in need of or in crisis and in need of help, there's not the resources available, which leads to long wait times, which alienates people from care, which is incredibly frustrating, which causes unnecessary suffering, and the cycle goes on and on and on. Next slide. When we think about, again, what a healthy community would look like, we would have inpatient care. We would have those 40 to 60 inpatient beds per 100,000 in population. But we would also have a variety of outpatient services. And we have some of these. Like there are some services available. But because mental health has been so underfunded, we haven't paid attention to it in the way we needed to. We haven't celebrated it. We haven't prioritized it as a society. Those services just haven't been built. And North Carolina is particularly behind in the continuum of care that we need, so that no matter what the illness that you have is, there's a continuum of care. Just like when I have a physical disorder and I go to the hospital or I go to my primary care, or there's physical therapy, occupational therapy, there's all the different levels of care. We've built those out in our society. We just haven't done that in the same way for mental illness. So this is where I spend my days. If you wonder, I talk about, if you came to my office, that's not actually what I do most days now, because I have the honor and privilege of leading WakeMed's charge to build a continuum of care. And so WakeMed has recognized that this is a need of the community and something that we have to do better on. And so we have committed to leaning in to build a 150-bed mental health hospital, which will be in Garner. We're in the process of getting ready in those design processes, and that should be online in 2027. And we're also looking to redefine how mental health is delivered in a whole health approach, because no longer is it acceptable to treat physical health over here and mental health over here and not recognize the complex interplay between those two. And so our mental health hospital will be attached to a 45-bed acute care hospital, and we want it to be a place that is welcoming, where families come, where the community comes, and that we can say you don't have to be ashamed to get mental health care. It shouldn't be hidden away where people hide their faces that they go in, but rather a place that's celebrated, an integral part of the community, so that we can help show the country, the nation, the world that we can do this differently, and that care can be dignified and celebrated and readily available. So, to the big question, how do you access mental health care? I wish that I could come here and be like, you called this number and you get this amazing service and it goes perfectly. The reason that people always ask me this question is because it's not easy. We're all smart people, and if it was easy, we would have it figured out, but the resources just aren't there. So I'm going to tell you that this is not perfection on this screen, but these are some resources that I think are really helpful and that I often turn to. So primary care providers, we have recognized the importance of our primary care doctors, our APPs, our PCPs. They are an incredible lifeline, and they take care of the whole person. And there's a new model of care called collaborative care, where they have a psychiatrist on speed dial, as I like to call it, and the psychiatrist works in the background to understand what's going on with the person and give recommendations. So you bolster your relationship with your primary care physician, but there's an expert in the background helping to drive the care from a mental health perspective. So I think this is a really innovative model. There's also a shortage of psychiatrists in the country, and we are one of the fastest aging workforces in medicine. I'll tell you, psychiatry has not been the most celebrated discipline to go in. I remember when I was in medical school and I said that I was going to be a psychiatrist, people were like, oh, you're too smart for that. Why would you do that? I think I made a fantastic choice. I think they all kind of think that too now as they see mental health coming into the limelight. But we really do have a shortage of psychiatrists, and again, expecting that shortage to grow as a lot of our psychiatrists age out of the workforce. So we still have some bumps to get over, and I think things like collaborative care will help us with that. The second thing I would say is ask your friends. The best referrals come from people who know someone and how it goes, and this helps us talk about mental illness. For a long time, this is not what we've talked about. We've been ashamed to ask this, or afraid that we'll make other people uncomfortable. But you get really good referrals and you open a conversation, which may change things down the line. The third one is look at your insurance panel. You know, mental ill health, we have carve-outs and this and that. Again, it's been underfunded, and working with your insurance company to understand what resources might be available to you through your insurance plan is always helpful. Psychology Today, really great website to get a therapist. Every time someone asks me, I really do go to Psychology Today. They write profiles, they tell you if they're accepting new patients, there's a picture. I mean, I think it's a really engaging resource. And then there's a new model of care. It's not new, but behavioral health urgent care. Just like there's urgent care when you stubbed your toe or have an infection, or you need to see someone quickly, there's behavioral health urgent care available as well for mental health disorders. And the RI International is a new company that they're not new, but they just opened up WakeBrook. So WakeBrook was previously run by UNC, and it closed down for a while, but it's back up and running. WakeMed is running the inpatient beds, and RI is doing the behavioral health urgent care. They're both on the same campus. Monarch also has a behavioral health urgent care, and the Hope Center in Fuquay Varina. And so if you just look up behavioral health urgent care on the website, you can Google it and find it. So that is not an exhaustive list of resources by any stretch of the imagination. Those are just some that I use frequently and find very helpful. All right, so the first one, any known research on trauma disorder that may have resulted from traumatic childbirth experience? I think this is the most fascinating area. I've been reading a lot about this and just trying to understand what happens even in utero. So I don't know if this was about what the mom experiences or what the child experiences. It can be traumatic for both. But there's new emerging research about what's happening in utero and what the fetus experiences, and then research around what happens in the early years before the child can communicate and talk about their feelings of what's happening and what's getting encoded in their brain. There's a really interesting center here, the Lucy Daniels Center that I just got to tour recently, and they are really focusing on therapy and helping kids who are kind of nonverbal, like before their verbal ages, very young children, which has not been an area where we've done a lot of therapy in the past. So absolutely, there is research around that. It's in its early phases, and I think we have a lot more to learn, but babies are absolutely experiencing trauma in utero, exposure to drugs, stress that the mom experiences as well as in their early life. I think about that a lot when my kids, I'm like, oh, wow. Like when I look back on it, that was not even something on my mind, and I was a high functioning parent. And so I often think about that for parents who have incredible stressors or maybe an active addiction or trying to figure out where they're going to live and how the child experiences that as well. So I think that there'll be more coming on that in the future. So the second question is, why would good therapists and psychiatrists be out of network? I'm going to hold my tongue about, the state of insurance and the state of healthcare, and just say it's really complicated. So, insurance companies' goal is to make money. They're for profit. And the negotiation with an insurance company can be really difficult, and the priorities aren't always aligned. And so the therapist or the psychiatrist has to figure out their business model as well. What I would say is that I think, companies are trying to reach their mission and vision and goals, and psychiatrists and therapists are trying to reach theirs too. And when they align, that's fantastic. And when they don't, guess who loses out? The person that needs care. So I don't think it is a desire not to treat or for people not to have care, but they're just not always in sync with one another. The second part is that there's a shortage. And so people that's the other part. And then often the reimbursement that you get from insurance companies or even public payers isn't aligned with how you could do it other ways. And it's a capitalist society. And so when you can take cash and get double or triple the amount, that's what happens. And that's how our society is built. So I think there's some reform needed. North Carolina has actually increased reimbursement rates for mental health care. That's been some of the work of our legislature and our governor and our Secretary of Health, Cody Kinsley. There's rate increases coming. I think there's a lot more momentum around this. And I think as we increase payment, get parity, make sure that we're covering mental health, that we have laws and expectations around that, I think it will get better. But it's been a really difficult place to be, and for everyone, but especially the people that need care. How do eating disorders fit into all of this? Yeah, so I didn't do all of these disorders and how they go in a bucket. So that is a smaller kind of niche grouping of diagnosis that I would think about as I tease the other ones out. Eating disorders are often associated with anxiety disorders. They often have some control that go with them. Often perfectionism, anxiety associated with them as well. So that would be thinking about those big categories because that's where most things fall. And as I'm learning about that, then I would be teasing out some more specific diagnoses like an eating disorder. And then let's see, is it common for a doctor to prescribe a benzodiazepine like Xanax or Ativan on a long-term basis? We've spent a lot of time talking about benzodiazepines. A lot of time. And if I would tell you the thing that I have made people mad about the most, it's benzodiazepines. So benzodiazepines are a medication that treat anxiety, and they're very effective at treating anxiety. So effective. And your brain builds up tolerance to them, and they can lead to addiction. And there are two life-threatening addictions that when you go into withdrawal, you can die: alcohol and benzodiazepines. So benzodiazepine and alcohol withdrawal can be life-threatening. And benzodiazepines work on the same pathway in your brain as alcohol. And so what you start with is anxiety, and what you can end up with, if you have genetic predisposition, you can end up with an addiction. So where is the line? Like, that's really complicated because they help, and they help in the moment. And if taken over a long period of time or a sustained period of time, for some people, that can lapse into addiction, which can have, or dependence. Let me say it, they can go into dependence, or if you go into withdrawal from that, it can be life-threatening. And so then even if you prescribe benzodiazepines and you have a provider who's prescribing them, or I'm in the hospital, so I work in the hospital setting, and I discharge you, and you don't have an outpatient provider who's going to provide benzodiazepines, then you're at risk for going into withdrawal after my prescription's done, because I'm not going to keep prescribing after I don't see you anymore in the outpatient setting. So the answer is, like so many things, is really complicated, and it has to be an individual decision based on symptoms, based on risk factors, based on relationship with a provider, and establishing what's a safe, effective treatment regimen that will get you to the outcome side.
Thank you.
Thank you, guys. I'll be around if you have specific to answer.
Thank you, Dr. Krempasky. That was wonderful. I hope all y'all learned as much as I did. I certainly learned a lot. I want to remind you, and I want to thank all of you who came in person and those of you who've joined us on Zoom today. I wanted to remind you about our next session, which is on August 25th, and will be presented by Angela Lassiter, who's an attorney at law. And she will talk to us about things like voluntary commitments, involuntary commitments, powers of attorney, healthcare powers of attorney, anything that you need to know concerning the legal system and mental health. And you can visit our events page on our website at welcomingwellnessnc.com and sign up for our newsletter. And if you do that, then you will get a Zoom invitation automatically for all of our presentations in case you can't be here in person. But I think there's a really big benefit to being here in person, because you get to talk to other people who are going through the same things you might be going through, and you know you're not alone. Our Welcoming Wellness presentations are free to the public, so we'd love to have you bring a friend and come back and see us again. One of our committee members said, you know, we don't have a staff or a budget. And I said, that's exactly right. No money, no budget. So if you have found any of this helpful, then there is a Donate Now button on the website, and we'd be happy if you would like to donate some for us. So Dr. Krempasky will be available for a few minutes to answer questions. And like I said, some of you had questions that did not get answered out loud, and she will be happy to help you with that. Thank you so much.